My name is Khalid El-Johani, and I'm one of the fellows at the Montreal Heart Institute. I'm originally from Saudi Arabia. I've been doing my training in Canada for the past 8 years, and it's a pleasure to be at Montreal Heart. Quickly, the patient is a middle-aged gentleman with previous significant past medical history. He is known to have coronary artery disease with the previous stenting of the RCA done a couple of years back. A COPD that was mild to moderate with some infrequent exacerbations, rheumatoid arthritis, and chronic steroid therapy with PMR. And he had multiple recurrent pulmonary infections. The most recent one was just a few months before his indexed procedure. So he presented to our emergency with TROPS negative unstable angina, and the story was not in terms of the angina, so we scheduled him for presenting MIBI. That did show that there is a very extensive ischemia with moderate to severe ischemia in the LAD territory, which was compatible with left main disease. He had normal LV function, and during the exam, at the end of the exam, the patient did have retrosternal chest pain, so he was sent directly back to the emergency department. It should play automatically. So this is the first diagnostic imaging.
Come back, click on the arrow. Can you go back to previous slide? Get it?
Yeah. So a caudal view of showing that it's distal left main disease for significant stenosis.
So this is a distal left main. Do you have a spider view?
Yeah.
But with a very small circ, right? You have like a huge LED small circ. We expect the right to be humongous with this, right? So it changes a bit. We're talking about left main. I mean, we have a ramus. There's a circ. The AV groove circ is quite small. There's a ramus. But we're not talking about a large circumflex. Does it make any? I think it's it's a diagonal maybe. I'm not sure. So at this point, I'd like to open the discussion. And you haven't shown the right. Do you have a shot of the right, Khalid?
Yes. I don't have a computer. It's only a pointer.
Small circuit.
Click on it. Oh, because you can't. Okay, yes. Can someone click on the image, please? It's sort of a moderate, like mild to moderate proximal RCA disease. Let's say we did an FFR that turns out to be negative on the right, which I think is indicated when you're embarking into doing something on the left main.
Well, we had PET rubidium that did not show ischemia on the RCA.
Yeah, but I wouldn't even believe this because he's got the left main disease. Exactly. He's got left main disease.
The PET rubidium you should.
Well, okay, yeah. It's like.
The maybe not, but the PET rubidium you really should.
We all thought maybe that's why we.
That's on Clear Medicine.
No, it's a PET rubidium. It's much better.
Anyway, that's we've all been burned by I don't know. I'd like to hear people on the panel, but we've all seen discrepancies between territories that are called. You know, if you want to see all the literature has always been built with nuclear medicine versus prognostic, not topography. We often overread and talk about territories, whereas it's never been shown to predict a given RE being diseased. It's never been done. So we got to be very careful in saying, oh, it's ischemic on the anterior wall, so therefore the right shouldn't be is non-significant. It is. We cannot say that.
Mainly in the presence of triple vessel disease or left main disease, they will catch the most severe ischemia that will be highlighted, and you could have homogeneous moderate ischemia elsewhere. So you
And a
cannot
good
just
example
rely.
is with the CTO. With the CTO, you always have the ischemia on the side of the CTO. You may have a significant left main. You'll never show any ischemia on the anterior walls. It's going to be all inferior if it's the CTO of the right. So I think, let's say we've done an FFR or not, turned to be a negative. Now, we've seen this distal left main, so that's the discussion right now. Do you have any other thing to present, Khalid?
No.
Okay.
What would be your intervention?
STS, the syntax score.
So do we have
data?
was an STS score calculated for that patient?
It was calculated, and it was in the low risk score.
The STS?
The syntax score.
Okay, and what about the STS?
It wasn't calculated in this case.
Okay, because the patient is known for COPD. We have no data on that, though. We don't know.
It was mild
And he's
to
on
moderate.
corticosteroid long term, so
Not
immunosuppressed.
frequently. No.
Yeah.
So this patient's got a pristine distal target for the LED. There's absolutely no doubt about that.
There's no OM.
For an IMA. He's got a distal left main. He fits into an Excel or Noble population for sure.
Yep.
He's got a big RCA, as we saw, a small circumflex. I'd like to hear what would be your approach, Bob, in your center. Like, would you be asked to see that patient usually, or any of your team? And do you think a hybrid approach would be a good approach on this patient?
So left ventricular function is normal, by the way.
Okay.
As is creatinine?
It's normal.
Normal.
The only thing is that he's a really big guy, 37.5 BMI, and he's got immunosuppressant therapy. He has also methotrexate and chronic steroids.
So this patient, at my institution, again, we got such a different variety of different cases, but I'm a very big proponent of hybrid for these cases. Specifically, this individual should not have a sternotomy based on these risks. So I would do a minimally invasive robotic-assisted LITA to LAD, or even direct approach harvest of the LITA through a thoracotomy approach. Avoid a sternotomy, do a LITA to LAD, and then the question is whether that circumflex needs to have something done to it or not. If it is, then I think that should be dealt through percutaneous techniques.
So, Jean-François?
He's a perfect patient for angioplasty. Perfect. It's the anatomy is favorable. Is at least a moderate risk for surgery just because of steroids. Surgeons don't like it usually, at least at my center. It will not be difficult, technically speaking. There's almost nothing in the circumflex territory, so you might only need to protect it and not even go back there.
Do you think it's a high likelihood of a one-stent strategy here?
Definitely.
Stefan?
The only thing that we need to take into account also is a disease on the LAD. The LAD is diffusely disease, and there is a disease in the mid-segment also. So
we
don't
see
know
a cranial view? I'm not that sure about that.
Look at this view, Stefan. You will see when your LED will get bigger. It's like almost at the end of the mid segment.
Can you play this view? Well, I've seen more disease than this. I can live with that.
Are you sure?
It's a good angle with the TV.
Yeah, Stefan, so we would never see this kind of a patient in the interventional program unless the surgeons were titillated by things like the immunosuppressive therapy and the big size, et cetera. If it's not optimal, then we would be asked to do PCI on this patient, but it's pretty straightforward. I agree. You would stent over the circumflex. I would always protect the circumflex.
So you're saying that if the patient has to say no, so for you to be, because the default would be surgery in your center for this.
Default would be surgery, yes. Still,
can it be justified with the data right now, or what's your opinion on that? Is it against your belief that the default is that way, or is it like culture?
It's culture. It's culture. Yeah. It's you have two data sets, right? One that's very positive, one that's not quite so positive. But this is very straightforward, low risk, and this is something we would normally do But if the patient was referred from an outside center to surgery, he would have surgery.
And I think, Stefan, that's the problem with that, because we all talk about the heart team and making a decision all together, but at the end of the day, who does what? So this patient needs to know that there is different approaches, but he needs to know that PCI is feasible with very good success. So who's going to go see him? Who's telling him that? Is it me? Is it the surgeon? Who says what and how?
Yeah, if this
And that's more of the problem now, I think, with the heart team.
Yeah.
I mean, discussing all together is okay, but when you discuss with the patient, who does it and how do you do it?
So I was in the CCU this week, and I had two patients, both with left main disease, both with syntax score between 22 and 28. And what I did is I approached the patients telling them that we have data showing for one patient who had an STS a bit elevated because of severe COPD, that his risk based on the Excel data for death, MI, and stroke at 3 years is the same, that he would have a 4% absolute increased risk at 3 years to potentially need a repeat revascularization with PCI, and that his outcome in hospital would be somewhat more demanding if he went to surgery. One patient said to me, I don't want to have any surgery. He made the decision based on this information and was dilated, left 2 days after his angiogram. The other patient, for personal reasons, his concerns of having to come back for a repeat PCI was too great. He decided to have surgery. This was Monday, and he's going to get operated next week, and will leave the hospital in 10 days. This is all irrelevant in terms of long life perspective, but I think we have to give the information to the patient, and they make the decision.
Yeah, there are very good points. Sylvain, you have any comments?
I think at South Lake, typically this patient would be presented in our combined rounds. We have PCI surgery combined rounds, and this case would be discussed among us. And what is interesting in our group, I think we are very pro-physiology guided revascularization, and pretty commonly surgeons actually require a FFR of some vessels of questionable severity before going for surgery.
So the era of bypassing based on
Blindly?
visual assessment is sort of disappearing progressively?
Well, I think our group, I think we are the, if not in volume, but in proportion, the largest center for FFR in Canada. We've done like 700 cases last year out of 2,000 PCI, so we do a lot of this.
So Dr. Glover, just a question, because you're fortunate or unfortunate, but let's say you have the chance in your center to have a variety of surgeons working differently that may have competitive thinking on the way they manage the cases, whereas interventional cardiologists, we would say, let's say for left main, more on the same page. How do you manage? How does it unravel on the daily experience when you have to sort of bring an art team around a case like that?
Yeah, this guy probably wouldn't get a heart team, I think. I think most of the interventionalists would calculate the syntax score, take the patient off, tell him he's going to have a good result with PCI, give him the option of surgery. But I think if the low syntax score, I think most of us take him off the table, talk to him about it, and then probably proceed with PCI. Our only problem is we do have some angiographers who are sort of older guys who haven't kept up, and sometimes some of these patients would slip through and be sent to a surgeon. Some of our surgeons would be very good. They'd come back to us and say, look, the syntax score is low, you guys should stent this. Some of our surgeons will just do it, won't tell us about it. So it's an imperfect, I think, process at our institution. We're trying to make it better. But yeah, some patients would slip through the cracks where they wouldn't have a discussion.
And if there's any discussion, if our team is involved, given the the variation in expertise in multi-arterial and everything, does it have any impact? Do you do ad hoc heart team approach? Therefore, you ask a specific surgeon to see a patient given his skill set?
Yeah.
Or how do you guys manage this?
David Gleaner is sort of the lead from the surgical point of view, so he's someone we would always talk to him about this. So we'd tell him, like, you're going to give full total arterial revascularization or you're not, and that would play into it for sure. But David's our go-to guy. He's usually available, and then we use Mark Ruel. So they're both pretty good about using multi-arterial grafts.
But I have a question for the rest of the panel, because we've been talking about PCI versus surgery, and we're talking about sternotomy surgery. My take on this case is the same as Bob. I would do just one bypass, robotic approach, Lima to the LAD, decrease the risk of the surgery for the patient, definitely, and I think in the long term, it's a good choice. But in most centers, and I know that, you don't have access to this option. But let's say you do. Would you say something different? Would you change your mind to PCI to surgery, or you would keep the same?
You have in Ottawa.
Yeah, in Ottawa we have it, so yeah. I mean, that's why we probably, David and Mark are the two that would do it, so we would discuss it with them. But I mean, David's very good, and he really goes a lot by syntax score and STS score. So I think in this type of patient, I think with the steroids and that, I think that I don't think he would have any problem saying PCI.
Eric?
So even though I recognize the limitation of the syntax score, it comes with a syntax score 2 calculator, which sort of tried to predict 4-year mortality. So I'd like to ask the group what people think the 4-year mortality for this patient is.
It's very low. It's very low. It's probably
Okay,
around
so
2 to
for
3%.
PCI, according to this, the 4-year mortality is 6.5%, and it's 22% for cabbage. 22. And that's just because of his COPD.
Well, how bad is the COPD?
Well, the system just asks if
Some people
they
just
have
get labeled with
COPD.
COPD, but if you do PFTs on them,
No,
it's
so
fine.
I started by saying it has limitations, but that's a potential additional tool that we could use to infer information for the patient.
I think we have a comment from the audience too. Huh? Don, you want to?
Don?
Yeah, thanks, guys. You know, as we progress, I've been doing this for many years. As we progress, we want to move from the surgeon as more as a consultant. So over the years, when we ask for a consult in cardiac surgery, the opinion that we generally get is, yes, I can do it. Not, do I think this is the best for the patient? Yes, I can do it, or technically, I can't do it. So my question to the surgeons on the panel, and you know, by definition, I think you guys are selected. You know, you're here, academic, but in your groups, in your various hospitals, when they get the consult for this patient, can you tell me what the mindset of the surgeon is besides, yes, I can do it? Because I can't believe that a surgeon would see this patient and say, no, I think we should do angioplasty. This is like a beautiful case for you guys, and if you have, if you believe in what you're doing, I mean, you're never going to say that something is superior than putting a mammary on that beautiful LAD. So I think as we go forward, what we want from your teams is to say, look, let's have a discussion here. I think we can do something good, but you know, maybe angioplasty is as good. Is that happening at your centers?
I'll speak for Southland. So we consult often with our PCI colleagues, and I'm not saying that just because Sylvain is here. We really do. So, and again, we try. This is going to sound a bit sort of airy-fairy, but we really do try to take a holistic approach to the patient. You know, it's not a patient isn't just a heart with a bunch of vessels on it or valves or what, aorta or whatever. It's, you know, it's the whole patient, and so you're right. You got to calculate you look at the patient and you might calculate a syntax score or an STS score. And frankly, while we're sitting here, I calculated this STS score based on the information that's presented to us. It's not high. It's 1.2% mortality risk. He's not a horrendous patient. But regardless, you go and look at the guy. There's still a gestalt to this, and which I suppose you get over with experience. Then decided, clearly this patient is too high risk or medium, or we could do it, you could do it. This is, or we, whatever the case may be. But we're not afraid to go back and forth or consult and determine what, based on our experience, what we think would be best for the patient. And ultimately, as has been said multiple times here, to present that data to the patient, and ultimately they're the final decision maker.
Before to move to the recorded live case, Eric, you alluded to patient preference. Just a little note of humor. When I go see a patient, I always say, you have the choice. We can go with a little hole here in your wrist with a little tube, and we bring this, and you're all conscious, and we do that. We all stand this, and tomorrow you're home. Or we just saw your chest completely open, put tubes, put your heart to a rest, open your leg all the way down. It might infect. You'll stay about 7-10 days, but you decide. You decide what you prefer. Okay?
Stéphane, we hope and know you don't do that, Stéphane.
Stéphane, I wanted to hear the surgeons.
Stéphane, continue with the joke with the stroke story about this. Do you remember the stroke story about that French interventional guy?
Yeah. That was. But the thing is that we can have a patient accept whatever we want if we are to be dishonest with the way we present things. And my point was that, Eric, you did it the right way. You presented the numbers and everything. Obviously, there's a big toll to pay with surgery on the short term, but we're all focusing on the longer term. But again, all patients will be pro to sort of a minimally invasive approach, and that's the reason why we're sort of enthusiastic to have you here and hearing about it.
You are right in the majority of patients. However, when we were recruiting for Excel and we are recruiting right now for Fame 3, some patients may understand it very well, and we said, if you are saying that the surgery is the gold standard, I want the surgery. Of course, some patients will prefer the small stick and the small tube, and if you are able to do it, you want to put me in a PCI group, so do PCI on me. So it depends on the way you present it, but it depends also on the patient's comprehension and what he wants.
Absolutely.
So, Stéphane, if you're the one in the CCU, you're going to present it that way. That patient's never going to hear that story from somebody else who's not an interventionalist, who's either a surgeon or even a diagnostic angiographer. We have a similar situation where one of our labs has a lot of diagnostic angiographers who do not do PCI, and in that particular lab actually we would not do left main PCI, we would do it in the other lab. So they actually come to my CCU already, I'm getting surgery. They've already been talked to by a surgeon, surgery is already waiting them, they're just coming to my CCU to wait for surgery. So now I have to convince them, no, you really shouldn't have surgery. And the problem is that in most cases, our idea of a heart team is that, yes, we get a surgeon to talk to the patient. Next thing you know, the patient's booked for surgery.
Yeah.
And so there is no discussion. I suspect we're not unique in that regard. I suspect this happens in many places, and it is a problem that somehow we have to resolve.
Yeah, I think it was. So for the sake of time, I think we're all having a very good discussion that will go on with the presentation of the case. You want to show the final result, basically what you did, Khalid?
Yeah. So technically, the patient was taken off the table, and discussion with the patient and the angiographer and his cardiologist was done. Not as dramatic as Dr. Renfrey used certain words. But the consensus discussion, including the heart team, was to do the primary PCI of the left main to LAD with the angiographer methods of using one stent technique and using side branch protection. with the nice result at the end after post-dilating the LED with 3.5 NC and 4.5 for the left main.
Can I highlight one issue? I think if we are to offer PCI, we need to be as anal as possible as interventional cardiologists to provide the best possible results. And this looks like a fantastic result in the left main. I have some doubts about the LED. I would have liked to have an FFR in that LED.
Yeah, it is now that the...
and that goes for all the PCI cases we're going to do. We need to use imaging if we have doubts, if we haven't used as big as we can.
But I think you should pull an IVUS for sure for that case anyway, because you're stenting a left main and you should put an IVUS.
We haven't done an IVUS, but the MLA in the middle LED is more than 5.0.
Okay. It's probably good.
But it's not an FFR, you're right. But would you really do FFR plus IVUS plus everything in every single case?
If we decide that we're going to do left main patients, yes, we have to. This crap about spending a little bit more money is nonsense. If we are to compete with excellent surgical results, we need to do everything that is possible for the patient. It's
especially
a special
that our stents cost about $200
exactly.
now.
This is what I want to say. Don't forget how much your DS costs nowadays. So let's take the FFR and assess it as it should be and decide if we would need to put another stent.
For this case, but we need to do everything we can.
I think for the sake of time, Philippe, we want to move to the live case.